Well, early-stage non-small cell lung cancer are treated in what we call the curative setting, meaning that the aim of the treatment is to definitely get rid of the tumor. This very often implies some multimodality treatment, some kind of multimodality treatment. If the patient can have surgery, the majority of the patients would also need some chemotherapy afterwards. If the patient cannot have surgery, many patients receive radiation and chemotherapy as the curative treatment in order to cure locally, but also to potentially cure the small cells at distance, the micrometastasis in the same time.
For early-stage non-small cell lung cancer, the standard treatment is considered to be surgery in patients who are fit. So this involves a lobectomy and lymph node dissections, according to the guidelines. And in expert hands, it's got good results. However, many of our patients are elderly. They may have had malignancies before, and they may not want to accept the risks associated with surgery. In such patients, the standard of care is stereotactic radiotherapy, high-precision treatments which can be delivered in between 3 to 8 treatments. And stereotactic radiotherapy has also been shown to be superior in terms of local control and overall survival compared to conventionally fractionated radiotherapy, which could take about 5 weeks to deliver, 5 to 6 weeks to deliver. So currently, the two options available to patients are surgery and stereotactic radiotherapy. And in fact, it's the patient risk factor and preferences that will increasingly play a role in deciding between the two. There are ongoing trials comparing head-to-head comparisons between the two modalities, but it will take a number of years before these trials are completed. The dose of stereotactic radiotherapy, which is considered recommended in the guidelines, is one of more than 100 gray biologically equivalent. So despite giving it in 3 fractions or 5 fractions, finally the dose required is considered to be more than 100 gray. That's is something which is safe to deliver in tumors in the lung periphery. However, as the tumors are more closely located to the middle of the chest, closer to the blood vessels, then the doses sometimes have to be compromised. So in patients with a peripheral lung tumor, the standard recommended dose is a biological dose of more than 100 gray, which is necessary for cure. There are currently 3 studies, ongoing studies where surgery is being compared to stereotactic radiotherapy in patients with early-stage non-small cell lung cancer. The Stablemates trial in North America has been open for a while. It's for borderline operable patients. The term borderline means that patients have a higher risk if they undergo surgery. The other study is the Veterans Administration trial, or VALOR, which is a large randomized trial for all patients with peripheral tumors from the Veterans Administration. And that will be a phase 3 trial and definitive trial accruing a few hundred patients. And there's a smaller trial going on in China, also in patients who at standard risk for surgical complications. So these 3 trials will inform us about the merits of either treatment in this population.
The role of chemotherapy in early stage is, of course, to help treating the local tumor, but more importantly, to treat or prevent the emergence of cells at distance, tumor cells at distance, what we call micrometastasis, the one you don't see on a CT scan or a PET CT, but potentially exist. So in that setting, if you deliver first surgery, all the patients with lymph node involvement or aggressive pattern of tumors will need 3 months of adjuvant chemotherapy. The group of Spain, Enriqueta Felipe and colleagues, have shown that you can also give the chemotherapy before. The result is more or less the same. Probably the compliance is better when you give before surgery, but it was really never really adopted by the community. It's because it also implies when you start with chemo that you have a staging of the tumor which is after chemotherapy. So you might miss some of the potential invasion of lymph nodes and so on. So your staging might be a little bit less common to interpret, right? So you can give neo or adjuvant, but it's more classically adjuvant. When you cannot perform surgery in a patient and you have to give radiotherapy, the same concern of micrometastasis exists, meaning that if you want to prevent the emergence of a distant disease as a relapse, you have to deliver chemotherapy too. Ideally in the same time of the radiotherapy, because both act in a synergistic manner, but if you cannot, one after the other one.